Today we will talk about the Helicobacter pylori. First of all, we will look at the characteristics of the H. pylori. H. pylori is a spiral-shaped rod-like bacterium. It has a length of 2.5 to 5 micrometer and a width of 0.5 to 1 micrometer. Its helical shape facilitates in the movement through the mucosa of the GIT. It has a flagella that is helpful in the motility of this organism and having 4 to 6 unipolar flagella. H. pylori is a gram-negative bacteria, so it will look pink in the gram staining during microscopy. Growth requirement H. pylori is a microaerophilic, means requiring low oxygen levels like 5 to 10% oxygen, and it requires enriched medium for the growth. Next, we will look at the epidemiology. Prevalence. Half of the global population is affected by the H. pylori, and it actually depends upon the geographical region, socio-economic status, and the hygiene practices. Poor hygiene practices means large spreading of the H. pylori. So prevalence varies according to the different factors. Transmission, H. pylori transmit through oral to oral route, fecal to oral routes. Means when the food or the drink affected by the feces, then that food or contaminated food or water when takes someone, then ultimately H. pylori transmit to the other person. And waterborne pathways. Risk factors, poor sanitations, overcrowding, and low socio-economic status are the major risk factors for H. pylori. It increases the chances of the spreading of the H. pylori infection in a community. Next, we will look at the pathogenesis. So we have categorized pathogenesis into two: colonization of the stomach and the tissue damage. So what factors actually helpful in the colonization of the H. pylori? So if you see in the figures, you will see the epithelial cells of the stomach. First of all, urease production. So H. pylori produces enzyme that is urease. Urease converts the urea into the ammonia and the carbon dioxide. So as we know that the H. pylori survives in the stomach and stomach having acidic condition. By this reaction, urea convert into the ammonia and the carbon dioxide. Ultimately, ammonia reduces the acidity of the stomach. And after that, the condition will be favorable for the survival of the H. pylori. So, bacteria produce urease. Urease hydrolyze urea into ammonia and carbon dioxide. Ammonia reduces or neutralize the stomach acid, and now condition will become favorable for the survival of the H. pylori. Next, motility. As we have discussed, H. pylori has helical shape and having flagella. Both these factors helpful in the survival of the H. pylori in the stomach and the movement in the mucous membrane. Adherence to the gastric epithelium. H. pylori adhere to the epithelial cells by adhesins. H. pylori has two most important adhesins, BAP-A and SAP-A. These adhesins helpful in the attachment of the H. pylori to the epithelial cells. Next, tissue damage. Two most important proteins that damage the tissues or epithelial cells. First is the cage pathogenesis island, encodes the cage protein. Cage A protein basically inject into the epithelial cells via the type 4 secretion system. These cage A protein inside the epithelial cell destroy the cytoskeleton, and ultimately the epithelial cells of the stomach starts inflamed. So this is how H. pylori causes the inflammation in the stomach, and that is actually the gastritis. Next is the VAC-A toxin. Cytotoxin A induces cell apoptosis of the epithelial cell. So epithelial cells, due to the VAC-A toxin, go towards the apoptosis. Second function that VAC-A toxin do, disrupt the epithelial junction. So epithelial cells having the junction among them. So these VAC-A toxin destroy the junction, and ultimately epithelial cells start disintegrating. And other contributes to the immune evasion. Immune system has low effect on the H. pylori. Next, manifestation. Asymptomatic infection. Most individuals remain asymptomatic, but the H. pylori can persist in his or her stomach. Chronic gastritis, inflammation of the stomach lining. As we have discussed, this KHA protein causes inflammation. Peptic ulcer, H. pylori is a leading cause of duodenal and the gastric ulcer due to the VAC toxin. Gastric cancers, chronic inflammation, long time H. pylori infection causes the significant risk factors for the gastric adenocarcinoma, mucosa associated lymphoid tissue lymphoma, mold lymphoma. Other conditions like dyspepsia can also be associated with H. pylori, iron deficiency anemia, and idiopathic thrombocytopenic purpura. Low platelets count in that case. How we will diagnose the H. pylori? We have categorized into non-invasive test and the invasive test. Non-invasive test, urea breath test, measures isotopically carbon label carbon dioxide in exhale air. Actually, we use the urea, and inside the urea, we have labeled the carbon isotopes, and we inject the urea inside the stomach. So, bacteria, as we know that the H. pylori produce the urease. Urease break the urea into the carbon dioxide and the ammonia. Now, carbon dioxide also having the labeled isotopes. When these carbon dioxides expel from the body, then we can detect this carbon dioxide having labeled carbon dioxide. So this is how we do urea breath test. Stool antigen, we can also take the sample of the stool and detect the antigen of the H. pylori in it. Serology, we can detect the antibodies against the H. pylori in the serum of the patient. So these are basically non-invasive. Invasive means we can take the biopsy through the endoscopy process, and we can go towards the histology, culture, and rapid urea test. So in the rapid urea test, we take the strip and we check the positive or negative result. If you see here, purple color will show the positive result and the yellow color will show the negative result. This is the rapid urea test. Molecular testing, PCR, that detects the DNA of the H. pylori. This is the most specific test. Next, if we look at the treatment, so first line treatment, that is triple treatment, in which you will see the proton pump inhibitors, clarithromycin or amoxicillin or metronidazole. So you will remember is with the cap the infection, C for clarithromycin, A for amoxicillin or metronidazole, and P for proton pump inhibitors. Next alternative regimen, that will be the quadruple therapy. You will remember it by the please banish my troubles, bismuth subsalicylate, B4, P for proton pump inhibitors, M for metronidazole, and T for tetracycline. So here, this is the mnemonic for the remember of the quadruple therapy. Antibiotic resistance, rising resistance to clarithromycin and metronidazole poses challenges to treatment. Prevention, how we will prevent the H. pylori? Improve hygiene. Proper sanitation and clean drinking water can reduce the transmission. Health education, awareness campaigns, and vaccine, but none are currently available for widespread use. Vaccine for the H. pylori. So what we have learned today, H. pylori is a spiral-shaped gram-negative bacterium colonize the stomach lining. Prevalence 50% of the global population affected by the H. pylori, and prevalence depends upon the region, age, and the socio-economic status. Transmission, oral to oral and fecal to oral transmission. Pathogenesis: H. pylori survive in the acidic conditions by producing the urease. Urease neutralizes the stomach acid. And inflammations of the gastric mucosa leading to gastritis, peptic ulcer, and gastric cancer also. So manifestation, you will see the gastritis, inflammation of the gastric walls, peptic ulcer, gastric adenocarcinoma, and the mucosa associated lymphoid tissue lymphoma. Diagnosis: non-invasive test, urea breath test, stool antigen test, and serology. Invasive endoscopy with biopsy, rapid urease test, histology, and culture. Treatment: we have discussed triple and the quadruple therapy. Prevention: improve sanitation, hygiene, and safe drinking water are crucial to reducing transmission. So this is all about the H. pylori. If you still have any question, you may ask in the comment section. Thank you so much.